The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, future doctors. I'm Jeff Downing, and welcome to another edition of Question Lab. We're going to take a dive into one of the most fascinating filtration systems ever evolved, the human kidney. Tonight, we're going to be thinking about renal, because renal physiology and pathology make up a big chunk of the Step 1 exam. And tonight, we're going to work on some of the test-taking strategies you need to tackle these questions with confidence. So we're going to break down how to approach the trickier vignettes and identify key clues that will guide you to the correct answer. So tonight I am joined once again by Dr. Abraham Titus. So Abraham, would you introduce yourself to the crowd?
Of course. Thank you, Jeff. So my name is Abraham. I'm a hematology and oncology fellow at the University of South Alabama. I've been a tutor with RX for quite a few years now and have helped many students such as yourself achieve their goals, their Step 1, 2, and 3. And I'm excited to go over some renal physiology today and pathology as well.
Excellent. And we also have Kate with us. So she's going to be answering questions. And we do have a little question box that we will encourage you to include your questions, comments, suggestions as we go along. Again, as future physicians who are preparing for one of the biggest exams of your career, we're not just learning about the kidneys, you're really learning how to think like the test makers. So we're going to work through some questions designed to challenge your understanding and try to show you, how to analyze each answer choice and eliminate distractors and really zero in on the right response, even when you're not 100% confident. So let's start talking nephrology. Don't be afraid to make educated guesses. Don't be afraid to be wrong. Each question that we tackle together is really just another step toward mastering the boards. And, just like the kidney, success in Step 1 is all about filtering out what doesn't matter and focusing on what does. So, tonight, as we go through these questions, we're going to, also work on, kind of conveying our approach, our methods for answering questions, because that's just as important, especially when you get to that point where you're feeling good about your knowledge, your understanding of some of these things, but you also need to be thinking about how you can methodically tackle these questions on test day. So we're going to talk about our approach as we go through this. Okay. So with that, I'm going to go to question number 1. And when I reveal this, you're going to see that there's something missing. Those are the answer options. So this is by design. We really want you to focus. And so the first thing we ask you to do is to cover up the answer options. And the reason we say, to do that is that we don't want you to be distracted or dismayed when you see an answer choice that you either don't know very well, or maybe it's something that's tripped you up in the past. Whatever we can do to help you stay focused and not allow your, any anxiety triggers to get triggered. So we say cover up the answer choices. And then step number 2 is read the lead in. And if you're new to Question Lab, or if you're not too familiar with the terminology, the lead in is the question here, right? So in this case, the lead in is treatment with which of the following is most likely to negatively affect renal function in this patient. Okay, so we want you to read that lead in first, because the question, offers a number of clues, as well as what it is that you're actually going to be looking for. When you're dealing with, long, and in some cases, very long scenarios, it's helpful to know what it is you're looking for, so that, again, this is about filtering, right? We're talking about the kidney tonight. So we say, read that lead in, you get an understanding of what it is you're looking for, what kind of question this is. And now you can kind of go into detective mode and read the vignette, which is what we're going to do right now. A 64-year-old man with a history of uncontrolled hypertension comes to the office for a routine physical. He smokes half a pack of cigarettes daily, and past surgical history is notable for femoral popliteal bypass on his right lower extremity. 1 year ago, his blood pressure was 136/94, but he did not receive any treatment for hypertension other than lifestyle modification advice. He was then lost to follow-up. Currently, his blood pressure is 160/100. Physical examination reveals 1+ pitting edema to his knees and bilateral abdominal roots. So again, treatment with which of the following is most likely to negatively affect renal function in this patient? Think about what your answer might be as I pass it over to Abraham.
All right. So, Jeff, just want to confirm that you guys can hear me. Switch headphones. Okay, sweet. So, and Jeff had some really, really good important points here. Reading the lead-in, again, most important thing, understanding what you're looking for, especially when you see those huge vignettes. You don't want to feel overwhelmed. You don't want to feel like, hey, you're over flooded with information, and you kind of want to just pick out what's most important. What we want to do right now is just highlight some of the keywords and kind of break it down and try to figure out what's going on. So let's go ahead and highlight the keywords. Okay, so going back to the lead-in, treatment which of the following most likely to negatively affect the renal function in this patient. So you want to think, is this not just asking for me for diagnosis? It's asking for treatment with which of the following that's going to negatively affect the patient. Okay. Now let's look at the vignette itself. So we have the 64-year-old guy. He has known uncontrolled hypertension. We know that he's a smoker and that he's had a history of a femoral popliteal bypass of his lower extremity. Now, why would he need to have that? So your gear should be thinking about that. And he's had notable hypertension, right? So it's 136/94. We didn't really do much about it to tell him, hey, cut down on your salt and exercise. And then he comes back 160/100. Now, key important features are always physical exam. You got to make sure there's abnormal physical exam. There's a reason why they're giving you 1+ pitting edema and bilateral abdominal bruise. So what is going to kind of be the underlying diagnosis that explains all of this? And then treatment, which can negatively affect renal function. So not what you want to give this patient. So what do you want to be careful not to give this patient? So think about that, kind of have a diagnosis in the back of your mind, and think of a treatment that you don't want to give this patient in the back of your mind before we reveal the options. Go ahead. You can reveal the options here. Awesome. Okay. So classic, 5 options here. You kind of want to recognize your most common medications we would use for blood pressure, and then kind of use those to come up with what's going on here. So I always like to start with option E and make my way to A, just so that I don't see an option I like and just click it right away. I always want to make sure I read all the options first, make sure I go with the answer that I'm most sure about. So option E, diuretics. Option D, calcium channel blockers. Option C, angiotensin converting enzyme inhibitor. Option B, aldosterone antagonists. And option A, beta blockers. So these are all, very good drugs, and we're going to use them all, in some form of practice or the other. But which of the following is the most likely to negatively impact or negatively cause or negative effect on patient's renal function? So go ahead and take a second, pick an answer, and think about why you're picking that answer. And we're going to open up the poll very shortly.
Okay, everybody. So the poll has been launched. Let's see. I'm going to go ahead and close the poll. About 3/4 of you have voted. And let's go ahead and share the results. Okay, so leading vote getter was answer choice C, angiotensin converting enzyme inhibitor. And it's kind of a close race for second between aldosterone antagonists and diuretics, but every answer choice here got double-digit percentage of votes. So So interesting. So let's go ahead and hide the results and let's share the answer. And the answer for question 1 is answer choice C, angiotensin converting enzyme inhibitor. So great job, everybody. Good start for the evening. This is it was a little challenging one to get us started here, but the key thing is whether or not you got it right, we're here to learn. So Abraham is going to walk us through this one. Abraham?
All right. Great job, guys. And again, this is a pretty tough question. And, we know in nephrology or renal, some of these questions, especially when it comes to the drugs and the management of hypertension, resistant hypertension, they can be kind of tough. Because we generally, if I see someone with hypertension, I'm going to be reaching for a lot of these medications, right? My ACE inhibitors, my calcium channel blockers are going to be great for controlling the blood pressure. But what's unique in this patient, right? So let's come up with a diagnosis, and then let's think about what the problem is. So of course, he has uncontrolled hypertension. He's a smoker. And why did he have that femoral popliteal bypass for a lower extremity? So he must have had some kind of peripheral artery disease, right? That's their hint of saying that, hey, he's had some previous atherosclerosis leading to peripheral artery disease, which then caused him to have this femoral bypass. Now, we know he's hypertensive, but pretty badly. He's 160 over 100. So this is kind of a higher level of hypertension than we normally would see. And on top of that, this bilateral abdominal bruit. Right? That's a buzzword that you guys got to definitely recognize. So what does bruit mean? Bruit just means an abnormal sound, right? So whenever I listen to someone's belly, if I hear a bruit, it just is like a noise that shouldn't be there. So that typically what it indicates is that there's a vessel that's stenotic. So that means that there's some kind of arterial stenosis going on. So that abdominal bruit with a history of peripheral vascular disease points towards bilateral renal artery stenosis, which can then lead to secondary hypertension. So his blood pressure is not only secondary to smoking and lifestyle problems, but the key finding in this one is a bilateral abdominal bruit, which indicates that he has bilateral renal artery stenosis. Okay, so that should be ringing some bells now. Once you know that diagnosis of bilateral renal artery stenosis, you should know patients with bilateral renal artery stenosis, we should not be giving them ACE inhibitors or ARBs. So ACE inhibitors and ARBs are contraindicated in patients with bilateral renal artery stenosis because it can negatively affect the kidney. What it can do is it can actually cause the kidneys who rely on that perfusion and the GFR to the kidney to get damaged further. What about the other options? You guys think beta blockers? Beta blockers can still be given in these kind of patients, and if they have any kind of cardiac history, we're reaching for that much earlier. So that's not a contraindication. Aldosterone antagonists. What are my aldosterone antagonists? That should also be thinking about, right? So those are my spironolactone, my eplerenone, and those are types of diuretics we can use, but not contraindicated in bilateral renal artery stenosis. Calcium channel blockers are also a great option for blood pressure control, particularly the amlodipine and the dihydropyridines. And the diuretics in general can also be used, but again, that's not the main point of this question. The point of this question is you understanding that this is the bilateral renal artery stenosis patient, and you want to avoid ACE inhibitors and ARBs in these patients. But great job, guys. Lots to learn from this question, and make sure you guys remember this for your future.
Okay. Well, we're off to a good start. Thank you, Abraham, for walking us through that one. So we're all warmed up and we're ready for question number 2. And as before, we have covered up the answer choices, and we are going to go to the lead-in, which is, which of the following is the most likely cause of this patient's condition? Okay. So again, one of those question frameworks that you're going to see quite a bit on step 1. So we know something's happening with this patient, but we're now needing to think about what may have caused it. So with that, let's go ahead and read the vignette. A 17-year-old girl comes to the clinic because of swollen legs for 2 days. In the past 2 days, her urine has appeared brown and frothy. 3 weeks ago, she had a sore throat and mild fever that resolved spontaneously. Blood pressure is 138/88. Physical examination shows 3+ edema to the midcalf. Urinalysis shows 3+ blood. So again, which of the following is the most likely cause of this patient's condition? Think through in your mind what that might be as I turn it over to Abraham.
All right. So this one's a little bit shorter of a vignette, but still lots of high yield and important information with every sentence. So you got to make sure you guys read these ones very carefully. Sometimes, you may think it's a shorter question, maybe easier. May not necessarily be the case, right? There may be lots of packed information in just one sentence that you need to decipher. So let's highlight some of the keywords in this one, and let's try to figure out what's going on here. So again, most likely cause is what we're thinking. So again, not just underlying diagnosis, but what's causing that? A 17-year-old girl, okay, they kind of give an adolescent, kind of female, swollen legs, okay. The urine has appeared brown and frothy. So what could be causing that dark urine? And then 3 weeks ago, had a sore throat and mild fever. Okay, that's important. And blood pressure is a little bit high for someone who's 17 years old, 138/88. If it's like, a 60-year-old person, I'm not going to freak out too much about that. But in a 17-year-old, okay. And then 3+ edema in the mid-calf. And urinalysis shows 3+ blood. So lots of little hints here to point at what's going on here and why they're presenting like how they're presenting. But the question is asking, what's the most likely cause of the patient's condition? So you want to think of diagnosis, then go ahead and let's think about what the cause is. So let's look at the options here. Let's try to take our time, think about what's going on here, and come up with a clear answer. As you can see, they're not just giving you straight up diagnosis. They're thinking about the mechanism of the diagnosis. And that's classic for step one, right? Step one's all about understanding the basic cellular level understanding of what's going on. So let's look at the options here and let's try to think about what's going on. So option E, type 3 hypersensitivity reaction. Option D, type 2 hypersensitivity reaction. Option C, thickening of the glomerular basement membrane without immune deposits. Option choice B, mesangial IgA deposition. Option A, fused glomerular visceral epithelial cells with normal appearing glomerular on light microscopy. Some of these are long, but they're all describing different conditions that we should be aware of. And I want you, even if you know this question for sure, try to think about what each of the other options could be referring to. And that's a good practice to always get into, right? Not just think about what one thing that the question is asking, but this way you can learn 5 things from the same question. So go ahead, take your time, think about what's going on as we pull up the poll.
Okay, everybody. So before I do that, I just want you to take a good look, especially at answer choices A and C, just because they're so long that our GoToWebinar quick poll only caught about 2/3 of it. So again, just want you to get a good look at that before I launch poll number 2, which I'm going to do right now. Okay, over 3/4 of you have voted, so I'm going to go ahead and close the poll, and let's see what we have here. Okay. Well, for this one, we got a really strong reaction, a type 3 hypersensitivity reaction. Almost half of you went with that one. And we've got, tied for second there between type 2 and thickening of glomerular basement membrane. But again, got votes across the board, but a much stronger consensus for this one. So let's go ahead and hide the results. And let us share the answer. And indeed, crowd's right. Answer choice E, type 3 hypersensitivity reaction Well done, everybody. There's again, a lot of information compacted into that one, but you guys did a great job. If you didn't get it right, though, that's okay. Abraham here is going to help us explain it.
All right. Great job, guys. Again, another important high yield one, knowing the types of hypersensitivity in combination with recognizing one of the most classic presentations of glomerulonephritis, right? So let's talk about this. Let's kind of break down what is happening in this patient and really what the big clues are. So first of all, let's come up with the diagnosis, right? So it's kind of a younger female and having swollen legs, okay? So and she has having brown, frothy urine, and then she has some swelling and blood in the urine. So whenever I think blood in the urine, I'm thinking maybe is this like a nephritic syndrome going on, especially in a young female. So nephrotic, I want you to think it's pure protein loss. So you can get the edema, and it's more just protein loss without the loss of blood and without that classic hypertension that you see. So when nephritic syndrome, you think about you're going to lose protein, but it's also blood, also associated with hypertension. And that's what you can see with that classic presentation. So there's some kind of nephritic syndrome. So which nephritic syndrome are we thinking about? Oftentimes, the most common things that make you pick between is post-infectious glomerulonephritis versus an IgA nephropathy, right? So option choice B is IgA nephropathy. And then that's something that they classically want you to differentiate to. Think days 1 to 3 after an infection. So if it's whatever, diarrhea, sore throat, upper respiratory illness, and then they come in with blood in their stool, urine, then I want you to think, oh, is this an IgA deposition problem, IgA nephropathy. But the fact that it's 3 weeks later, so 2 to 3 weeks, I want you to think things like strep, staph, some other infection that's causing this. And this is more of a post-infectious glomerulonephritis. They used to call it post-strep, but they found out that things more than strep can cause this. So now they changed the name to post-infectious glomerulonephritis. And you guys always want to be aware of the latest name that they get for it, right? So if you're using an older version of maybe one of the textbooks, they may use the old names, but you got to be aware they're going to update some of these names, and you got to be aware of that change and not be thrown off on the exam when they call it post-infectious. All right, so let's kind of break down why is it type 3 hypersensitivity. So what is type 3 hypersensitivity? Type 3 hypersensitivity is when you have that antigen-antibody complex and the deposits in the glomerulus. So that's very classic, and that's what's seen most commonly in nephritic syndrome. And a kind of key hint that I'll give you guys is that most of my nephritics, and when I'm thinking about hypersensitivity, are going to be type 3. Type 2, the only one that I'm really going to be thinking is type 2, is Goodpasture syndrome. And that's that classic where you get the respiratory involvement and the kidney involvement at the same time. So classic presentation is going to be that separate, and that's going to be my option choice D for type 2 hypersensitivity. What about the other options? Option choice, let's see, you have C, a thickening of the glomerulus membrane without immune deposits. So that I'm thinking about diabetic nephropathy, right? There's no immune deposits, but you're going to have thickening of the glomerulus there. So that's kind of what they're going to go for. And option choice B, like I said, was IgA nephropathy. And this is A, that fused epithelial one that they're talking about here. You want to think more about, minimal change disease, where they talk about the podocytes, but then on light microscopy, it looks completely normal. But when you look at electron microscopy is when you see these fused podocytes and things like that. Really just recognize what each option is as a different syndrome. And then option choice E is a more blanket term that covers a lot of different conditions. Most important in this one being post-infectious glomerulonephritis. So great job, guys. Take a lot away from this question. Even if you got this right, the 80% of you guys keep trying to learn more and more and really understand your nephritics and nephrotics. Very high yield for nephrology.
Okay. Well, you heard it from Dr. Titus. So let's go ahead and I want to take a quick stretch break, get up, kind of move around a little bit, and talk a little bit about why we're all here together tonight, or depending on where you're at this morning. If you're finding, Question Lab helpful, you're really going to love having 24/7 access to USMLE-Rx and our QMAX question bank. We've got over 5,000 board style questions for step 1 and step 2, each written and reviewed by experienced faculty to match the style and difficulty of the questions you're going to see on the boards. And people ask, what makes RX special? Well, besides sessions like these, every question comes with detailed explanations that, step you through the reasoning process, right? And they all are supported by relevant bricks and flash facts and express videos and high yield topics. So it's like, having a study group in your pocket, right? It's available whenever you're ready to practice. And we also have, performance tracking that helps you identify your strengths and weaknesses. So, in theory, you can study more effectively. So if you haven't tried USMLE-Rx yet, head over to USMLE-Rx.com. If you haven't taken the free trials, start with that. And you can see why, tens of thousands of students worldwide, trust us as their USMLE prep partner. Okay. So with that, let's get back to mastering the renal system and renal pathology. And we're going to get into the second half of tonight's event by going to question number 3. Once again, we've covered up all of the answer choices. And what do you see a little bit differently here? Yeah, you're going to see some labs here. So again, what we do is we start by reading the lead-in. So let's start there. Which of the following is the most likely explanation for these laboratory abnormalities? Okay, kind of a straightforward question, considering that, shorter vignette, but a number of lab values. So with that in mind, knowing what it is that we're going to be looking at, let's read the vignette. A 30-year-old woman is brought to the emergency department after collapsing on her front lawn. Her medical history is unknown. On arrival in the emergency department, her pulse is 108, blood pressure is 98/54, and oxygen saturation is 92% on room air. And we have a laboratory analysis, so you can see what the serum labs and arterial blood labs show. So I'll let you look at that. And then again, which of the following is the most likely explanation for these laboratory abnormalities? Think about that as I pass it off to Abraham.
All right. So, would it be renal question lab if we had done some questions with lots of labs and a little bit of acid base mixed in there? So this is a very high yield topic to understand, and acid base kind of spans both the pulmonology chapter as well as the renal chapter. So it's one of the multi-system questions that USMLE loves to ask, and it's not going to leave you throughout step 1, 2, and 3. So you want to get really good at interpreting these guys. And this is a classic BMP and arterial blood gas where you get lots of information, but you want to interpret them and understand what's going on with the patient. So let's highlight some key things going on here. Let's go over these labs and let's kind of talk about what's it's telling us. So again, explanation for these lab abnormalities. So there's lots of abnormalities on these labs. Kind of highlighted some of them that are abnormal. Everything but the sodium looks like it's abnormal. So we'll kind of talk about that and, what can we draw from these labs? So 30-year-old woman, okay, and she collapsed. We don't know why. We just found collapsed. We don't have a medical history. Otherwise, she's young and healthy from what it seems like, right? But then maybe not healthy, just young. Heart rate's up and blood pressure is down. Oxygen saturation 92%. Okay, it's a little bit down, but not like hypoxic. We would say below 90. And look at our labs, right? We got some hypokalemia, potassium 3.4. Chloride's running a little bit on the high side. Bicarb is running low, 15. pH is low at 7.3. And PCO2 is a little bit on the high end. So how do we interpret this? And what are we going to kind of take away from this? Okay, so first of all, you got to kind of understand where we are in terms of the situation, and then use the labs to connect the dots. So let's look at these options. Let's try to figure out what's happening with this patient and, come up with a diagnosis and explain what's happening. Okay. So option choice E, spironolactone use. Option choice D, heroin overdose. Option choice C, furosemide. Option choice B, diarrhea. Option choice A, diabetic ketoacidosis. Right. So this is all acid-based, where you want to classify them as either metabolic or respiratory, and either acidosis or alkalosis, and then connect those to find the underlying diagnosis, and then match that with option that fits that. Each of these can cause a unique, different lab abnormality, and you want to match the one that the patient has with the correct one, with the clinical history to help guide you. Very classic question. You want to get really good at these. So go ahead, take your time, think about this one, and take the right answer that you believe.
Okay. Hope you guys have an answer in mind here as I launch the poll. Again, what do you think is the most likely explanation for these lab abnormalities? Okay, let's see. About 3/4 of you have cast your vote, so I am going to get ready to close the poll. And let's see. So we'll share the results. Looks like question 3 tonight was pretty much a 2-horse race. Almost half of you thought that diabetic ketoacidosis was the most likely explanation, while almost 1/3 of you thought diarrhea was causing these lab abnormalities. And then really third place was kind of was split between the other 3 options. Okay. So with that in mind, let's go ahead, hide the results, and reveal the answer. And the answer is answer choice B, diarrhea. So something in this question was leading quite a few of you to diabetic ketoacidosis. And there's a good reason for that Abraham is going to break down for you right now. Abraham.
All right. Well, great try, guys. I think this is a tough one, like Jeff mentioned, and DKA is definitely a good differential in this situation, especially looking at just the clinical picture, right? So you got this young female passing out and you can't really explain it. And they're not giving you a glucose to really go off of, and, she's tachycardic. Sure, if you just got that much, I would, buy that DKA picture. But really, what sells it, right? So this is a question to use the clinical history to help you, but really you can't pick an answer just based on that. You need to understand how to interpret the labs. So that's what the key is here. So let's break down these labs. Let's classify her as what does she have. Okay. So first of all, whenever I deal with acid-based questions, the 3 things that are most important to me are going to be my pH, my bicarb, and my PCO2. And based on these 3, I'm going to classify them into one category. So first, pH is low. So I'm thinking acidosis. Okay. Is this a metabolic acidosis or a respiratory acidosis? Well, my bicarb being low, and my PCO2 being low, well, which is going to be contributing to the acidosis the most? Well, my bicarb being, right? So the ACO3 being 15 points towards a metabolic acidosis. So that's step 1. Step 1 is understanding if this patient is in a metabolic acidosis. And why is the PCO2 low? Because she's compensating, right? She's breathing really fast to try to get rid of that acid in her body. So metabolic acidosis. Now, whenever I hear someone has metabolic acidosis, there's a reason why they gave the rest of the labs. What do I need to do first? What do I need to calculate? I need to calculate my anion gap, right? So that number that you guys learned before, the anion gap is very important to calculate every time I have a metabolic acidosis. So in this situation, how do I calculate anion gap? It's sodium minus chloride plus bicarb. So in this situation, it's the 140 minus the 116 plus the 15. So it comes to about 9. So you guys can kind of skip that. The normal value is around 12. So if it's anything below that, we're good. So this is not an anion gap metabolic acidosis. So that's the big clue in the situation, right? So DKA, option A, is an anion gap metabolic acidosis. So you would see an anion gap greater than 12 in those patients. In this situation, diarrhea can cause metabolic acidosis, but it's a non-anion gap metabolic acidosis. And I knew this would be the two options that would really trip a lot of people up, but I just need you guys to have that kind of reflex to every time I see a metabolic acidosis, I need to calculate anion gap. Anion gap is very easy. Sodium minus, sodium is the positive, right? So you're doing the positive minus the negatives. So the negatives are chloride and bicarb. You can ignore potassium. Just do sodium, 140 minus 116 plus 50. And then you do the math on that, it comes to 9. So it's 115 plus 116 comes out to 131. 140 minus 131 is 9. So that 9 is less than 12. So that's anion gap not present. So using that, I would get to the answer of diarrhea. Let's look at the other options. Furosemide is a loop diuretic, right? So how does furosemide work? Furosemide leads to what's called metabolic alkalosis. So this is through, depletion of hydrogen ions and volume depletion. That's something important there. Heroin overdose, that's a very classic situation where you have respiratory suppression and respiratory acidosis because you're not breathing. So in that situation, you would expect the carbon dioxide to be high and the pH to still be low, but that would be more of a respiratory driver as opposed to a metabolic driver. Spironolactone leads to metabolic acidosis. That's because it's the potassium-sparing diuretic and it works a little differently. And that's going to be your big differentials here. Okay, so spironolactone, metabolic acidosis, furosemide, metabolic alkalosis, heroin overdose, respiratory acidosis, and DKA is an anion gap metabolic acidosis, whereas diarrhea is a non-anion gap metabolic acidosis. There's lots of little mnemonics to remember the anion gap. I think mud piles is one of them. There's a gold mine, I believe that was another one. There's lots of them, and then first aid has some great ones on there. So make sure you guys review those, and there's not just for memorizing, it's for understanding as well. Great job.
Okay, everybody. There's a lot to take in there, and yes, there will be math on step 1, right? So good job, everybody. So with that, we've got one more question tonight. Question number 4. Again, we'll have a raffle here at the end as well as a special offer. So with that, let's go ahead and open it up. Oh, and look at that. We've got some more lab values for you. So in this case, of course, we've got the answer choices covered up. And the lead-in is, which of the following acute metabolic processes most likely induced this patient's current condition? Okay, so obviously something critical is happening with this patient. But again, this is a great example of why you want to read that lead in first. Completely helps you, get the right filter on as you're getting into the vignette and the lab values. So with that, let's go ahead and read the vignette. A 55-year-old man is brought to the emergency department because of nausea, vomiting, abdominal pain, and altered mental status. He reports recent binge drinking after being fired from his job 2 days ago. His medical history includes hypertension and chronic alcohol overuse. He is afebrile but tachycardic and tachypneic. Abdominal examination reveals diffuse tenderness. And here are the lab studies. So again, looking over those labs, which of the following acute metabolic processes most likely induced this patient's current condition? Think in your head what you might see once those answers come out. and I'm going to pass it over to Abraham.
All right. So we got another pretty tough one. This is kind of a very basic science heavy, giving you lots of labs, giving you kind of a history that's important, but really you need to be able to kind of think a few more steps in advance for this question. So tough question to end the night, and we'll talk about this for sure. But let's kind of first break down what's most important in this question. Let's highlight some important words and let's figure out what is this question really asking. So again, let's throw the highlights up. All right. So follow acute metabolic process. Okay. So you want to think about what's happening to this patient and then what's happening metabolically. So that could mean on a microscopic level, that could mean on a cellular level, that could mean something like that. So you want to think metabolism, think a little bit of biochem thrown in there with my renal and connecting the dots here. Let's go from the beginning. 55-year-old man, nausea, vomiting, abdominal pain, altered mental status. So kind of, okay, some classic pictures. And he has binge drinking. That could explain a lot of this stuff. So fired from a job, and then he started binge drinking. And he has tachycardia, tachypnea, and he has diffuse abdominal tenderness. And it fits with the whole alcoholism kind of picture here. Now let's look at the labs here. So you have, again, some acidosis with my bicarb being 9. You see potassium 3.3, which is a little bit down. Chloride 95. Glucose of 40. And lactic acid or lactate of 9.5, which is significantly elevated than my normal range. So what's going on and what's inducing this current condition? This is a tough question, and I want you guys to think about it a little bit, but really using what we talked about before, right? With that acid-base stuff in combination with the picture that's going on here and connecting the dots and then thinking about it from a biochemical standpoint almost. Which metabolic process is inducing all of this? So let's look at the options here. Take your time, think about what's going on, and let's pick an answer. Option choice E, thiamine deficiency. Option choice D, overproduction of NADH. Option choice C, inappropriate induction of gluconeogenesis. Option choice B, elevated pyruvate levels. And option choice A, decreased levels of glycerol 3-phosphate. So again, that's very much a biochem-like question, but this fits into the chapter of renal when it comes to my acid base, right? So you need to know these multi-system questions really well and kind of connect the dots. So what do you think is going on in the situation based on these? And this is a very step one, very high yield style question. And I want you guys to try your best, think about what's going on, and take your time and pick the right grade.
Okay, everybody, let's go ahead and close strong. Let us know which of these acute metabolic processes most likely induce this condition for this 55-year-old male. Also want to give a shout out to everybody who's been participating in the chat tonight in the question box. Lots of great questions. I love to see the thought process, and hopefully, and again, we can't always get to every question just because we've got a couple of hundred folks with us here tonight. But again, always good to figure out where some of those knowledge gaps might be, and then hopefully get the kind of clarification that is going to help you on future tests. Okay, let's see. About 60% of you voted, so I'm going to keep it open a little bit longer. Definitely don't want you to leave this last question of the night unanswered. Okay, so I'm going to close the poll and let's share the results. Okay, kind of an interesting spread here. Answer choice D took about a third of the votes. About a quarter of you went with elevated pyruvate levels, thiamine deficiency right after that. So, I don't know. An interesting spread. Again, a lot of this is about plausibility, right? And so I think there are some things in here that, make, all of these options potentially plausible. So let's go ahead and hide the results. And let's see what the answer is. And the answer is overproduction of NADH. Okay, so great job. You got, that was the highest vote getter for another tough question. But again, for the 2/3 of you didn't get it right, that's okay. This is the time to get it wrong, right? Because as Abraham walks you through the explanation, you're going to have a much better chance of getting this question and questions like this right when it matters. So Abraham, take it away.
All right. So, great job, guys. The ones that got it right, If you didn't get it right, don't worry about it. This is a very tough question. And this is a little bit cheating. It's a little bit of biochem when we talk about renal. But, remember, step one loves multi-system questions, loves to integrate my renal, my biochem, with my pulm, everything combined. They love these kind of multi-system questions. So let's figure out what's going on with this patient. Let's try to categorize him. And then let's figure out what the metabolic process was. So we'll start with the clinical side of things, right? So we know he is an alcohol user, so chronic overuse, and also has these signs and symptoms that point towards hypoglycemia, and then his labs point towards metabolic acidosis, right? So we kind of see the bicarb being really low, and the underlying cause of that, they give it to you, lactic acid, right? Lactic acid is 9.5. And we know lactic acidosis is one of the anion gap metabolic acidosis. So ethanol can induce hypoglycemia and lactic acidosis. So that's a very important thing to understand. So acute alcohol intoxication, what can happen? So he's a binge drinker, right? So if you acutely drink a sudden bunch of alcohol, it can overproduce something called NADH in our body. Okay? That NADH can then trigger your body to make more lactic acid and subsequently cause hypoglycemia. So why is that? Let's dig a little bit deeper. Let's get into the biochem of it all. Let's get way down to the glycolysis pathway and the gluconeogenesis pathway. I don't need you to know every single step, but need to know high yield clinical steps. So in this situation, remember, ethanol is kind of a toxin in our body, and our body has to get rid of it. So oxidization of this ethanol is done by NADH in the liver. Okay, so you have alcohol dehydrogenase and acetaldehyde dehydrogenase that gets rid of this. In doing so, we end up oxidizing a bunch of NADH to NAD. Right, so a high ratio of NADH. You have more NADH and less NAD. So when I have high levels of NADH and low NAD, that in turn will limit my supply of pyruvate, which needs for gluconeogenesis. So what do we need gluconeogenesis? To make glucose. That's why you get the hypoglycemia side of things. And that also will trigger through the biochemical system, leading to pyruvate converting to lactic acid, which then lead to lactic acidosis. So it's a little complicated when I just kind of just say it out. When you look at the actual diagram, when I follow the gluconeogenesis and look at how alcohol works and how it's broken down, it will make sense. I need you guys to really understand this because, alcohol use is very prevalent in the US and they do love to test about it. They want you to know everything from the biochemical, what's happening level to the more clinical liver cirrhosis and, withdrawal symptoms of alcohol when we talk about psych and neuro side of things. So those are all very high yield. That's why I really wanted to throw this question in there, but great job if you guys got it right. If you didn't, the other options are also kind of very tricky. So let's kind of quickly go through the other options, make sure why those aren't right. So option choice A, decreased level of glycerol 3-phosphate. Again, in this situation, your low pyruvate levels would actually lead to an increased level of glycerol 3-phosphate. And that wouldn't really fit with this clinical situation. Again, pyruvate would be reduced as well, not elevated, right? The idea is that I'm consuming up all my NAD. So I can't use up. I won't be able to make pyruvate in order to make glucose, gluconeogenesis. Inappropriate induction. No, it's actually the opposite. Gluconeogenesis is inhibited. That's why you're hypoglycemic. And then thiamine deficiency, we always learn alcohol and thiamine deficiency is very important, but that wouldn't really explain the hypoglycemia and everything, right? The thiamine deficiency, you can see it, but it's going to lead to kind of a more of a chronic alcoholism picture as opposed to acute. Acute alcoholism, I want you to think overproduction of NADH, which can then lead to inhibition of gluconeogenesis and overproduction of lactic acid. Definitely high yield, definitely kind of tricky question here, but I hope you guys were able to follow me and understand kind of the nitty-gritties of the biochemical side of alcohol overdose. All right. Great job, guys.
Fantastic. I've placed the link for tonight's test in the chat. So if you've got RX 360 Plus or QMax, you can access it there. You can also just copy down the QIDs if that's easier, but plenty of ways for you to go in and dig further, especially if you got, if there were a couple of these questions that you struggled with and, you want to learn a little bit more. Obviously, as I said earlier, you can, there's plenty of things that you can draw from, including the bricks, including the express videos that will, again, help you understand some of these renal topics even further. So great job, everybody.